I'm going to try in about 6 or 7 minutes to cover what has taken 20 years to accomplish. So that's kind of the task. But 20 years ago, two physicians, Dr. Vincent Felitti and Dr. Robert Anda, Felitti from the Kaiser Permanente in Southern California and Anda from the CDC, published a paper called Adverse Childhood Experiences. Like many papers, it didn't create an immediate explosion. People barely noticed. But in the last 10 years, and as people were following up on that original research, it has really transformed how we think about, many of us think about healthcare, how we think about social services, how we think about criminal justice, how we think about how communities ought to react and build resilience in their communities and build health. Well, this started with Dr. Felitti, who in Southern California, working for Kaiser, so this is an employed, middle-class population. He was running a wellness and obesity clinic, and he couldn't quite figure out why some of his patients did really well. They lost weight, kept it off. Some patients didn't do quite so well, and some patients basically failed the program entirely. And so what he did, which was brilliant, because he was Kaiser, he created a survey that basically asked people, what happened to you in your life? It's sort of a life scan. Tell me the things that happened. It was very broad. He got 17,000 Kaiser patients to fill this out. And then because it's Kaiser and he had all their medical records, he could connect what had happened to them as they reported it to their medical conditions, right? Nobody had done this before. So when he and Anda from the CDC looked at this, they discovered that there were things that happened in early childhood, adverse events, abuse and neglect, that had a profound association with later life health, things like heart disease, etc., as well as later life health behaviors, like substance use, etc. And I'm going to tell you the 10, give you a sense of the 10 adverse childhood experiences that they identified. And a lot of them, as you will hear them, have to do with the connection between an infant, a child, and their caregivers. It's about attachments. So physical, sexual, and emotional abuse, physical and emotional neglect, intimate partner violence in the home with somebody who has substance misuse, mental illness, somebody who's incarcerated, or parental separation and divorce. So that collection of 10 things, if you have 4 or more of them, they found, you had a much higher risk of those chronic diseases. Some of the leading causes of death in our country, heart disease, lung disease, liver disease, but more profound was the risk you had of behavioral health and high-risk behaviors. So there was a 10-fold increase if you had 4 or more ACEs in IV drug abuse later in life, a 13-fold increase in attempted suicide, a 7-fold increase in alcoholism, and a 3 to 5-fold increase in depression, male to female. So this came out in 1998. All the results were published. It was followed by many other studies, and it took a while for the world to understand the implications of this. And one of the key things that happened was that ACEs sciences was connected to developments in neurobiology and brain development and brain science. And the connection was that people realized that these adverse childhood experiences were happening at a very critical time in human development. It's when the infant, when a human being is building the brain, and they're building their physiology. So you can imagine that a child who is in a safe, secure, nurturing environment with caregivers who were there for the child at all points has a different physiology and develops different kinds of brain pathways than a child who is in a chaotic environment where at some points, if they're in need, somebody comes and helps them. At some points, somebody doesn't come. At other points, somebody comes and yells at them. A totally chaotic environment where it's very hard to create a stable view of the world because the world is unstable. And on top of that, it is a situation in which the body physiologically is constantly under stress to a level where all stress hormones are just on supercharge. And so we talk about toxic stress, and this begins a process of toxic stress that can be reinforced throughout life. Now, as you will hear from the panelists, this science, the understanding of this connection between early childhood trauma and later health events, has really changed a lot of clinical practice. There are many things going on, but not just simply in clinical practice, also in social services, in criminal justice, but most importantly, I think, on the community level. There are communities coming together, including communities in Oregon, who are saying, we understand ACEs, science, we understand brain science. This cannot be solved by one sector alone. We all have to work together to make the changes that will happen so that we will build resilient communities. There are hundreds and hundreds of schools across the United States that are working on programs that are ACE-informed, and you'll hear about what's happening, one of the schools that's happening here. There are dozens and dozens of communities that have resilience building collaboratives, that have ACE-informed collaboratives. Our own experience, I am from Health Share of Oregon, our experience in this, which in a certain sense underlines the importance to us as a society of ACEs, was that when we began to be a CCO, one of our mandates was that we focus on high utilizers, those people who are constantly in the emergency department, constantly in the hospital over and over again. The people who drive providers, they say, what's wrong with these people? They just keep coming back, I've done everything for them, etc. So when we finally got close to this population, we sent people out into the community, we connected with them in their space, we learned about them, we learned about their histories. One of the things that really stood out was their challenging childhoods. One of the threads that ran through this population in a very strong way was that these are individuals who had extremely challenging childhoods. Childhoods that didn't prepare them for school because they didn't learn social emotional regulation. They weren't ready for kindergarten. They had trouble at school. They ran away from home. They dropped out of school. They got involved in drugs. They became homeless. They got incarcerated. They got jailed and incarcerated. Just one cascade of bad thing after another, and their options become worse and worse and worse. And by the time we see them as high utilizers, they are considered to be one of the problems of healthcare spending in America. They're the 10%, the 5% who use the 30% or 80% of the dollars. For us, we understood that they're not really high utilizers, they're trauma survivors. And they are trauma survivors whose life course began very early on. And for a healthcare organization that is responsible for the Medicaid population, Medicaid pays for over 50% of the births in the state of Oregon, we saw that as a fundamental part of how we needed to change what we did as a CCO. So we have focused on we started with a focus on high-cost adults, and we started focusing on early childhood because we understand that the problems we're dealing with in society have their roots. And this is what people in ACEs science have been saying forever. The cost of these ACEs is huge to society. It's a huge burden. We moved as a healthcare organization from thinking about what's wrong with them to thinking about what's happened to them. Many have found that the science of ACEs and the brain science work. Once you understand it, once it's in your head, and once you see that lens is there, it's really hard to see the world in the way that you did before. I remember a conversation I had with the head of the school board in a small community in the northwest part of Oregon, and she had been to an ACEs conference. I think she'd actually seen Felicia present and saw the slides, etc. And she came back to her school board and said, we're doing things completely wrong. We need to change everything we're doing. We need to change how our school operates in a very fundamental way. And on top of that, we need to change how our community needs to take on this issue. This has to be a community issue. And they have actually done that. They've done some amazing work. So our hope for this panel is that it sets that fire in you. And if you have that fire in you, we hope it burns a little bit brighter after this panel, because it is clear that this is a problem that we all need to solve. It is not a problem that any one of us can solve individually.
Let's jump right in with Dr. Nadine Burke Harris. You opened your clinic in 2007, and you immediately saw a number of young patients who had a whole variety of childhood traumas and a lot of unexplained health issues. Is there one patient who sort of crystallized for you the mystery and the issues involved?
Yeah, so there was a patient that I talk about in The Deepest Well, Diego, who was a 7-year-old boy who was brought in to see me by his mom because his teacher had recommended that she take him to his doctor because she thought that he might have ADHD and thought that he might need medication. And when I saw him, a few things jumped out at me right away. He was adorable. But he was also itty bitty. So he was really little. And in fact, I had to, when I looked at him, I had to double check my chart, because even though he was 7 years old, his height was the 50th percentile, the average for a 4-year-old. And over the course of doing my physical examination and doing my history and physical, which is what we doctors do, what I discovered was that in addition to being little and having troubles with his behavior, he also had eczema, and it looked like he also had asthma. And traditionally I would have gone about addressing that in the way that I was trained to address it in medical school, which is, okay, I know the treatment for asthma, I know the treatment for eczema, I know the workup for a kid who seems like they're not growing very well, and I know, which forms I'm supposed to give to assess for ADHD or attention deficit hyperactivity disorder. But the thread that really changed my perspective was the history part of my history and physical. When I asked Mom when this child started having his behavior problems, she mentioned that it was really after he had experienced a sexual assault at age 4. And then when my x-ray of his wrist, called a bone age, looking at what his skeletal maturity was, that came back, and that was also at age 4. And I started just asking myself the question, what is going on in this child's body? Is it possible that these things are related? When the ACE study came out, people thought they knew a little bit about this connection. They thought that, oh yeah, well if you have a rough childhood, you're more likely to drink and smoke and do all those health damaging behaviors. And so really we already knew this.
They had an idea of what the causation was.
Yes, there were these preconceived notions. And in the time between the paper was published and the time I read it, one of the things that was very interesting for me was I had the opportunity to also read the research that showed that even if a person doesn't engage in any health damaging behavior, they're still at higher risk. In fact, the effect of health damaging behavior only accounts for about 50% of the increased health risk from adverse childhood experiences. And so that was really, I got to digest that all at once. But the further out I get in this work, there's another piece that I think is really important, which is that the science is not enough. We have to pair the science with advocacy. And in most of the medical world, a lot of that advocacy comes from 2 places. One is drug companies, right? People didn't even know they needed Viagra until, some of these problems were made very, very apparent to us, right? But the other is patients and parents and families and communities who have a loved one who are affected by that condition. And then they go out there and advocate. And that is, I think, what's been so powerful about ACEs is that we had the science, but what I think we've seen a lot more of in the past decade now is the advocacy, and that is what we need to continue to push forward to see the change that we need in our society. When we look at health conditions, I'm the last person to say, oh, there is no pharmacological solution here. From my standpoint, we have to remember that drug companies help us cure cancer, right? They help us manage diabetes. They help us, manage heart disease, all these different things. So if folks want to come to the table, right, and be part of the solution, and if patients who have a history of ACEs can have healthier and better quality lives because we do a better job in developing pharmacotherapies, I'm all for it. But we also know that when it comes to an issue like ACEs and toxic stress, the solution goes far beyond a medication that you're going to give in clinic or what happens even in the doctor's office. We need to look at changing the way that our entire society responds to this issue. Right now, there are a lot of things that a lot of our institutions are doing that are actually exacerbating the problem. School discipline policies, right, that are reactive and punitive instead of being part of the healing solution and implementing some of the trauma-informed and trauma-responsive practices that we know that we can be doing in schools. But every bit of research tells us that early intervention improves outcomes. Full stop. There's no debate on that. So in order for us to do that, we need to be doing routine screening for ACEs in primary care. And so that was the absolute first thing that we started doing, was screening our patients for adverse childhood experiences so that we could begin doing that early intervention that we know improves outcomes. So when we understand the biological mechanism of how adverse childhood experiences leads to toxic stress, this overreaction of our fight or flight response, we can get really detailed in the biochemistry and the physiology of it. But what all the research essentially tells us is, number one, safe, stable, and nurturing relationships and environments are healing for kids, right? That's pretty simple. So the treatment is reducing the dose of adversity and enhancing the ability of the caregivers in that child's life to be a buffer to the child's stress. Now, that's easy to say, and for those of us doing it, it's hard to do. It starts with helping the caregiver recognize their own history of ACEs and understand what's going on with them so they can recognize when they have an overactive stress response and how they can make different choices for themselves and for their children.
So we started about 5 years ago with asking the ACE questions to our parents, really with the idea of trying to identify which families might need some more support from us in understanding how their trauma might affect their own parenting. So our questionnaire really has a couple of parts. We start with the ACE questions themselves, and then we have a survey that talks about resilience, which really is the antidote, so to speak, to ACEs, and then asking what sort of resources families might be interested in, and with that just kind of launched to see what would happen. Was really that the families felt like they needed this. I think that many families who have experienced trauma have in the back of their head that they may somehow pass that trauma on to their kids. So it's a worry that is in the back of their mind that is unspoken. And when that unspoken worry is put out on the table, they realize that they now have a partner in their pediatrician, someone who's going to walk with them through this journey and really help them to figure out how to do better than what was done to them. I think that most people come to their pediatrician thinking that we tell kids to eat their broccoli and we deal with their ear infection or whatever else, but to actually bring their social history and their past history of trauma into the conversation is new. And so for me, the goal of the screening really is to get to that point where people realize that they can have that conversation with me. The message is that these social pressures and these traumas and things that are going on in people's lives have more potentially effect on somebody's health than what's going on with us giving shots or antibiotics for infections and things like that. That if a family is given a set of instructions from me, and this happens all the time now, where I'll say that the family needs to go to physical therapy and a neurologist and blah, 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 and then the mom will look at me and say, that's great, but I need to get food on the table. So that's the thing that's actually preventing that family from good health, because if they're at that level of need, then they're not going to do any of the rest of it. And so I think that as providers, we have this sort of misperception or preconceived notion about what we call non-compliance, like the families that don't follow through on any of our recommendations. And what the ACE work has taught me is that none of those preconceived notions are true. That the things that are really barriers for people achieving good health are social things. I think that the best medicine in these stories is really the medicine of listening. And there have been good studies that look at what makes a person who's experienced trauma feel like they heal. The Survivor Voices study, for example, that the Trauma Healing Project in Eugene put together, the thing that was most correlated with a trauma survivor feeling like they were healed was having been listened to with compassion. And I don't think that takes a special skill set, it takes intention.
First of all of the work that I do is done within the primary attachment system. So even if I'm working with an 8 or 10-year-old or a mother-baby dyad that may be a 4-month-old, it's always done within a safe adult system because children learn and co-regulate through their attachment system. So it always happens, whether that be the mom is directly involved in the dyad and we're working, or they're just watching. But in terms of how it looks with kids, this is the beautiful thing about children, right? I was telling this group of co-panelists here, on Tuesday in my office, I had a little boy, his parents are first-generation Americans, and the narrative of their family is such that the parents both went through extreme amounts of trauma getting to the United States, and dad especially presented with a lot of anger. And so I taught these young boys in this family, 5 and 7 years old, the concept of flipping your lid, which was initially introduced by Dan Siegel, but essentially it's teaching them about the neurobiology of their brain at 5 and 7. And so when I was interacting with this little boy on Tuesday, and I could see that he was talking about a situation where dad typically would have flipped out, but didn't. And I saw his whole body tense up. I said, "What happened to you?" And he said, "Dr. Stoeber, I lost my prefrontal cortex." And I said, "Where did it go?" And he said, "It flipped." And I had taught him that brain model at a very young age, that if you don't have organization and logical thought, you're left with that fight or flight response. And so even a child at 5 understood that intervention and is beginning to change the pattern of how he responds to trauma in his family. Portland has really embraced the study of ACEs, thanks to both national speakers like Dr. Burke Harris, but also people like Dr. Gillespie, who has introduced it to the mainstream pediatricians in the Portland metropolitan area. But it's been really within the last 3 to 5 years. And so part of the work I've done is to train local pediatricians on what ACEs are, how to become trauma informed, and then what do you do? The biggest question I get from pediatricians is, okay, I understand ACEs, this is really important, get it, what the heck do I do now? And that's been my work with them, is trying to help them build a skill set so they know how to respond when the trauma is presented. And if you're scared to ask, at least go in with the mindset that 64% of all people have at least one ACE. And that there are so many people that you're interacting with on a daily basis that have trauma that their body has absorbed. And they're trying to do their very best to parent kids every day. So the first thing is ask or assume that there is trauma that's there. And the next thing is know that just being, I call it being their present supportive other, this adult in their life, and sitting and being willing to hear their story and shifting that lens from what's wrong with you to what's going on and how can I help, what's your story, that's the first step. And then giving them some specific tool sets. Really what we've done is we've created an entire curriculum of what we call resilience building initiatives for a group of pediatricians in Portland so that they feel empowered when they walk into an exam room, whether it be a family with ACE scores of 7 or a family who's doing quite well but still will benefit from attunement and attachment.
Well, at Lot Wickham, we have a variety of systems in place to build relationships with kids, and it sort of starts with the beginning of the day, where kids used to come in and they'd come in the cafeteria and it was loud and overstimulating, and we realized that that was re-triggering kids. And so we switched our day to start with in the classroom with breakfast.
For everybody.
For everybody. And so our school is 100% free and reduced lunch, and so everybody gets the opportunity to have breakfast. And so instead of starting their day either missing breakfast because that's too overstimulating for them, or starting with an argument with somebody in the cafeteria or something, they can start in the safety of their own classroom. And it starts slow. It doesn't start immediately with academics. And so the teacher can have an opportunity to sit with the child and start building relationships with them. So if a teacher knows that a particular child has significant trauma or something, that they can start their day greeting them and saying hello to every child that's coming in, but that particular child might be able to spend a few minutes with them before the formal day starts. And then depending on what happens and how that child displays behaviors as a result of their trauma, for some children, you know, they move into the fight, flight, or freeze response. And if it's a fight response where they might go under tables, the first grader, I'm thinking of a first grader that might get upset and knock over chairs or go under a table or something, instead of looking at that child as, oh, I gotta call the office and they have to be disciplined and be suspended or something, we have pause areas in every classroom. So a teacher has been trained on trauma and would be able to sort of begin identifying signals for what that might look like. They might, each child, they might be able to understand what those behaviors may be, like maybe the child starts pushing things first and be looking for those, and then might prompt the child to say, honey, do you need a break? You know, do you want to go to the pause area or take a fidget or give a putty or something like that? And then maybe that would help that child regulate and find an opportunity to find me or another person that child has a close relationship to maybe have a conversation to find out what more is going on if they didn't have the time to do that. My principal, Kathy Lehman, helped to initiate that a couple of years ago, where kids, if the pause area still isn't effective for them, they can't regulate in that space, or the space for some reason or another is too triggering, they can get a break in the wolf den, and that's staffed all day. Kids can go there, and there are people there that will, you know, hold space is what I call. It'd be that listening ear that are trained and are aware of trauma responses, or maybe the child just needs to, we have different sensory items there, or there's puzzles, or there's drawing, or there's headphones with music, or there's yoga, or there's a tent that they can hide in, or there's a couch, or there's blankets, or there's adults there that will listen to their story. And what we found is that allowing the child to go there, and usually we set a timer for 10 minutes, because really your body wants to naturally regulate. And when you're in fight, flight, or freeze, if you can get to a place where you feel safe, your body will naturally begin regulating. Because like doctors aren't trained, teachers aren't trained about trauma and how to respond to trauma. And vicarious trauma, when they are going to school to learn to be a teacher, they don't learn about sexual abuse, physical abuse, domestic violence, you know, suicide. And when a child comes in who's 5 and helpless and tells them that, you know, they were sexually abused the night before or physical abuse, it begins to wear on a teacher, and they need an opportunity to get some support for that. So we do that. That's one of the biggest things we do at Wickham, is we have myself, a social worker, and another social worker, meet with teachers individually every other week to kind of debrief some of those situations and look at their own self-care.
We see kids where there's a worry of abuse or neglect. So the majority of kids get referred to us by child protection or law enforcement. So a child or a family has come to the attention kind of the system, and that's where the referral comes. But really referrals can come from anywhere. So it might be a therapist, it might be a parent that calls up and says, hey, this is what my kid said, what should I do? Another doctor might refer them from primary care, schools. So they come from a variety of situations. But you know, we work together with a lot of other community partners, which is great actually, because complex problems like this, one system can never fix. So it really requires collaboration and communication among systems. So working with detectives and caseworkers, therapists, primary care providers, and families all together is really what allows us to communicate and identify problems for families and for kids, and kind of start them on the path of healing. When you don't talk about a problem, it doesn't go away. Like, it's still there, and it just festers. And so it's just like, you know, RJ said, Nadine said, I think everybody said, just being real, slow down, take the time, and just listen. That's the first step before what support systems do we have, where do we need to refer you to, counseling, detective, you know, whatever it is. Just listening actually is the opposite of traumatizing. It's validating their life, because what happened to them doesn't go away because I'm too anxious to talk about it. I was a general pediatrician many moons ago. I've been doing this work in child abuse clinics for about 23 years. But we get to listen, we get to be authentic, and we get to spend time. So that's probably the best gift, actually. But we work in teams of 3. We have a medical provider, which is a pediatrician or a nurse practitioner. We have a forensic interviewer who can really spend the time talking with the child. And while myself and the interviewer are seeing the child, we have a master's level therapist, a family support person that's actually spending time with the parent or caretaker, taking care of them. Because, screening for ACEs is not just the child and it's not just the caretaker, it's both. And so, so we do that. For people that work in a child abuse clinic or professionals that maybe aren't doctors or interviewers but work with a child abuse clinic, it's kind of its own little world, and we can do a really, really good job with what we do, whether it's case investigation or child protection, safety in the home, or our assessments that we do. We can do a really good job. How well do I pass them back to RJ, who's their primary care doc? Not so well. So by increasing his awareness at his clinic, and by me recognizing that other systems get it now too, what I've gotten in my own little world, it makes that handoff a lot easier, a lot smoother. And then when RJ gets the kid, he goes, oh my gosh, I don't know what to do with this. He's like, yeah, we got this. Thanks for doing the assessment. We can take it from here. So I think just the overall care improves, and then the trauma to families improves, because they don't have to go back to primary care and think, oh, I can't talk about this stuff with my primary care doc. It's like second nature.
There's a great experiment that we had in Oregon Youth Authority, and Dr. Gillespie talked about a culture, which we quite often talk about. Our biggest challenge was changing our perspective from a quote-unquote correctional culture to a developmental culture. And that does not mean that accountability doesn't exist, but that culture actually begins with safety. And safety is the most important for all of us. Safety and well-being. And what we build on that, and this really, we started this for our children that we were in care of in Oregon Youth Authority, and then we extended that to staff. Because when these kids come into the system, as tough as they look, as tough as they act, what they're really missing is a sense of connection, self-respect, self-worth. And what most of us are missing or after is time. If any of you have time, I'll buy it. I'll pay big price for it. And what you have when you are incarcerated, all you have is time. And if that time is spent in contemplation, meditation, in fact, we're now offering meditation classes, then you can really begin to connect with that source of internal power, which replaces that sense of false power, carrying a gun, or being tough, because that sense of internal connection to that power can help you overcome any adversity in life. So if we have a collective vision of that healthy individual that we want to turn into society as an adult, then I think we all agree that we want that person to be healthy, we want him to be crime-free, we want them not to be on public assistance, not depressed, have enough level of education to support themselves and their family, and most importantly, live a life of purpose and be happy. So if that's our mindset, then every step that we take should be aligned with that outcome. So then, hitting a kid over the head is not necessarily the best next step to get them into that place, even though that kid might be coming at you with aggression. So accountability can be put in place after safety and a caring relationship is in place. And then you really begin to see engagement by kids, engagement by staff. And that leads to building a community. And the community, lack of a community is what has brought us to this place, both in correctional facilities, youth correctional facilities, and really in the broader community. And is that we actually did a bit of deep dive into the data, because we had an issue with isolation. When a kid misbehaved, hit, assaulted, did other things, we would put them in isolation. Well, science knows, studies show that that is significantly harmful to youth. When we actually dug deep down into this data, we realized that these kids that were experiencing the most instances of isolation were not the most aggressive, And there are very few kids that are really criminally minded, but they didn't have that mindset. In fact, they had come into the system with significant trauma. 100% of them were on psychotropic medications. LGBTQ kids, kids that actually could not regulate their emotion. They did not have the skill set that they needed in order to communicate. And when we mixed them in with the rest of the kids, and in fact, they had ended up in the juvenile justice system because no other place would take them. In fact, today, in youth correctional facilities across the nation, there are many kids that don't belong there. They're there because there are no systems, public systems, community systems to take care of them. So we were forced to create a program that focused on emotional regulation, trauma-informed care, skill building, and giving these kids a community that they could feel that they belonged to. Within 8 months, we had, these kids were experiencing the most instances of isolation and fights and assault. Within 8 months, we had a 77% reduction in fights and an 84% reduction in isolation. That is the impact of dealing with kids like human beings in a trauma-informed way. And
a couple of things that I envision. One is that our educational system, on that form that every kindergartner needs to have signed by their doctor in order for them to enroll in kindergarten. It says they've gotten their immunizations and they had their TB test and they've had a physical. And that there's also just a little checking box that says they've had an A screening. And it doesn't have to say what the score was. It just is an indication that some medical professional has screened this child for ACEs, and that is a prerequisite for kids to be able to enroll in kindergarten.